Before going into detail about Wernicke's aphasia, let's break down exactly what aphasia is. Aphasia is an acquired language disorder caused by brain damage, typically on the left side. People with aphasia may have trouble talking, understanding, reading, and writing. A common misconception is that aphasia causes a loss in cognitive ability. However, a person with aphasia may have difficulty retrieving words and names, but the person's intelligence is basically intact. Aphasia is not like Alzheimer's disease. For people with aphasia, it is the ability to access ideas and thoughts through language, not the ideas and thoughts themselves, that is disrupted. But because people with aphasia have difficulty communicating, others often mistakenly assume they have intellectual disabilities. The most common cause of aphasia is stroke-related injury. According to the National Aphasia Association, about 25 to 40% of stroke survivors experience aphasia. The other leading causes of aphasia include traumatic brain injury, brain tumor, brain infection, brain surgery, and progressive neurological diseases. Wernicke's aphasia is caused by damage to the Wernicke's area in the brain. This is located on the temporal lobe of the left hemisphere, specifically on the posterior section of the superior temporal gyrus. Wernicke's aphasia, also known as fluent or receptive aphasia, is characterized by impaired comprehension, jargon-filled speech with nonsense words and word substitutions known as neologisms and paraphasias, poor repetition, limited awareness of deficits, and intact sentence structure, articulation, and intonation with lack of meaning. The following recording is of a patient with Wernicke's aphasia. Take a moment to look for the common characteristics associated with the disorder.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment. Talk with the people over there. They're diving for them at the moment. But they'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
sort it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment they don't show a darn thing.
The iPad that we were doing. Like here?
I'd like my change for me and change hands for me. It would happen. I would talk with Donna sometimes. We're all with them. Other people are working with them and them. I'm very happy with them.
Good.
This girl was fairly good and happy. And I play golf and hit other trees. We play out with the hands. We save a lot of hands on hold for people, for us, other hands. I don't know what you get, but I talk with a lot of hand for him. Sometime. Am I talking any more to say it?
All right. Thank you very much.
Thank you very much. I appreciate it. And I hope the world lasts for you.
Thank you. It's been a pleasure. Bye-bye.
Have a good day.
The main purpose of assessment of aphasia is to distinguish it from other related conditions such as motor speech disorders or cognitive communication disorders. Conducting a chart review is imperative in order to get an overall picture of the patient and help to determine a differential diagnosis. Components of the chart review include gathering personal data, etiology, previous diseases or related disorders, medications, physician notes, physical health problems, vision and hearing screenings, and progress notes of any previous treatment. The following tests are both standardized and provide a comprehensive assessment for aphasia with classification. The Western Aphasia Battery has the ability to evaluate content, fluency, auditory comprehension, repetition, naming, reading, and writing. But it is not as comprehensive as the Boston. The Boston Diagnostic Aphasia Examination tests conversational and expository speech via conversation and pictures, similar to the Western Aphasia Battery. It takes longer than the Western Aphasia Battery, but it is more comprehensive. The SOP can informally assess pragmatics, speech, auditory comprehension, reading, and writing. Informal assessment of speech can include speech productions at the single and sentence level. The patient can complete recitations and sentence completions and naming tasks. The SOP should informally assess the patient's auditory comprehension abilities at the single and sentence level. Have the patient respond to prompts to identify body parts or follow directions of given carrier phrase. Many variables affect auditory comprehension, such as the patient's ability or inability to hear the question presented, predictability, redundancy of the questions, and the clinician's speech rate and stress when presenting questions in order to elicit appropriate responses. When informally assessing a patient's reading abilities, the patient should read at the single and sentence word level and match printed word to spoken word. The SOP should calculate reading rate to determine how well the patient can read and comprehend under normal time constraints, and the SOP should calculate reading capacity to determine how well the patient can read if they have as much time as they need. The patient tends to do better with reading capacity. When informally assessing writing, the SOP should have the patient write single words, copy text, write a story, and complete automatic sequences such as the date and signing name.
Intervention for aphasia may vary. In general, the aims of aphasia, as described by ASHA, include restoring lost language abilities, strengthening intact communication skills, compensating for impairments by teaching strategies and using AAC devices, training caregivers to communicate more effectively, facilitating generalization of skills to various contexts, and educating all involved about aphasia in the course of treatment. How these aims are incorporated into intervention, however, will very much depend on the individual needs and wishes of your patient, as well as your skills as a therapist. The general conclusions regarding the amount and timing of intervention are as follows. Treatment pays off in all periods of recovery. Aphasic individuals should receive therapy as early as possible. Payer policies that deny claims from reimbursement during later stages of recovery should be changed. Longer therapy sessions, around 2 to 3 hours a week for about 5 months in acute or post-acute settings, have found to be the most beneficial. The primary predictor is medical compromise.
Procedures and treatment of Wernicke's include these 4 steps. Reading comprehension, such as match a printed word from an array of 4 pictures. Which of these 4 pictures goes with this word? Oral reading. Can you read the word aloud? Repetition. Now say it after me. Lion. Auditory comprehension. Now which of these pictures is a lion? Here are several strategies you should use when speaking to patients with Wernicke's. Use gestures when you speak, as they can represent objects or actions while you're talking. This helps the person pair the auditory with a meaningful clue. Write down keywords while speaking. Using more than one method of communication is crucial to helping someone with aphasia understand. Talk about things that are relevant to right now. You'll find that "do you want a drink" when you're at the dining table is understood better than "how are you getting to the doctor?" with no immediate context. Don't shout if the person isn't hard of hearing. Raising your voice doesn't make someone understand you better. Slow your speech when talking. Pause frequently for them to catch up. Most people with aphasia cannot process spoken language at the same rate that they used to, so slow your rate of speech a bit. This does not mean use a tone or phrasing you would use with a child. It means pause between sentences and do not use complex language sequences. And last, be close enough to maintain eye contact. Don't talk to them from across the room or from the other room where they cannot see you. People with aphasia need context and clues to assist with their comprehension.
Specific treatment plans for Wernicke's aphasia include PACE, in which you have a box of cards with people performing various actions and the clinician describes the action as the patient tries to guess what they are doing. The second is TWA. This therapy involves the patient having a list of words and is asked to match the words with pictures, read the words aloud correctly, repeat the words without printed stimuli, and select the correct word after hearing it from a group of words. The third treatment includes the SFA. Therapy activities include naming a target picture, naming semantic features, eliciting semantic features, recording on a chart, producing a name, and using a chart to help list properties, location, actions, group, and use of target words to help the patient recall a word. The fourth intervention is TAP. This intervention plan targets word finding or getting stuck. The patient's rate between stimuli is monitored, and the patient is made aware of various strategies to encourage word retrieval. The fifth intervention is conversational script therapy. The patient will practice various scripts in several situations as the clinician begins at the word level and progresses to the conversation level. The patient is eventually asked to write his or her own script. The sixth intervention is the VAT. The patient is asked to trace and match objects to line drawings, objects to pictures, and is taught various gestures to indicate an absent object. The seventh intervention is the RET. The clinician targets scaffolding and building conversation by elaborating on what the client is discussing. This is similar to script therapy. The eighth intervention is the MIT. The patient follows an intonation pattern to help facilitate his or her speech. The last intervention I will mention is the SPPA. For this intervention plan, the patient is shown a picture with a sentence below and is asked to fill in a blank. This is used to increase proper grammar at the sentence level. A few things to keep in mind when treating aphasic patients are that the patient needs to understand that it is a degenerative condition, meaning that they will always be aphasic. It's just a matter of level. It is important that the patient is treated one-on-one with the clinician to ensure optimal results. Have a structure, but don't die by it. Change things if the patient does not progress, and be open to trying new things in therapy materials and activities. Also, prepare for generalization. It is important to involve patients and caregivers in therapy planning and implementation.